Welcome back to the deep dive. Today, we're plunging into a topic that has, well, utterly transformed modern medicine: minimal access surgery.
Hmm.
You know, the kind of surgery where you end up with tiny scars instead of huge incisions, less pain, and you're often back on your feet much faster.
It really does sound almost too good to be true sometimes, doesn't it?
Exactly. It sounds like magic, but it was real.
It is, and it's really a revolution in how we approach procedures. Ones that used to require, significant trauma just to get inside the body.
Right, just to get access.
It's where technology and surgical innovation really meet head on.
Absolutely. And thanks to the detailed material you've shared with us, we're going to take a full deep dive today. Our mission really is to unpack and understand everything that's in this material.
Get right into the weeds.
Yes. Get to grips with the core principles, the techniques, the advantages, the limitations, the cutting edge, even the really critical details of patient management and training.
Because the goal is to understand this, like the professionals who live and breathe it, right? The elite level.
That's the aim. This material provides such a comprehensive view, guiding us through the evolution and, the current state of minimal access surgery.
It's definitely complex, but incredibly fascinating. And we're going to try and dissect every key concept presented here.
Great. So let's start at the beginning. Let's unpack this foundational concept first. What exactly is minimal access surgery, according to this material?
Okay, so the definition provided is quite precise, actually.
Yeah.
It's described as being driven by technology and innovation.
Right. Tech is key.
Definitely. And its core aim is to achieve the surgical goals, therapeutic outcomes, but with minimal somatic and psychological trauma to the patient.
Okay, so it's not just about fixing the problem, it's how you get there. Minimal physical trauma from the access itself.
Right.
And minimal psychological impact, too, like from a big disfiguring wound.
Precisely. And that leads directly into the key characteristics they highlight: reduced wound access trauma and just being less disfiguring compared to the older conventional techniques.
And the payoff for the patient, for the healthcare system, what are the benefits mentioned?
Well, the material lists some really compelling potential benefits. Things like cost effectiveness, which is huge for health services and employers.
Because people get back to work faster.
Exactly. Shorter hospital stays, potentially shorter operating times in some cases, faster recuperation for the patient, and sometimes, though not always, improved operative precision compared to open surgery.
Less physical insult means faster recovery. It just cascades, doesn't it? You can see why this became so popular.
Absolutely.
But this wasn't an overnight thing. Let's take a quick glimpse into the past, the history of MAS. Where did this whole journey begin?
It actually started surprisingly early. The first experimental laparoscopic procedure was performed by George Kelling way back in 1901.
1901. Wow.
Yeah, he called it cilioscopy, and it was done on a dog. He used air to create space and a cystoscope, an instrument normally used for the bladder to look inside the abdomen.
That's incredible. Using existing tools in a totally new way just to peek inside the body.
Exactly, early exploration. And this was followed by Hans Christian Jacobaeus performing the first thoracoscopy, looking into the chest cavity, in 1910. Again, using a cystoscope.
Okay, so chest access too, early on.
But for decades, really, these remained largely experimental procedures, not mainstream at all.
So the idea was there, but the tech and the techniques just weren't ready for prime time yet.
Pretty much, not for widespread clinical use. The significant breakthroughs took much, much longer. Patrick Steptoe in the UK, he developed laparoscopy for treating infertility.
Ah, okay, a clinical application.
Yes, an important step. But the truly pivotal moment, the one everyone points to, came in 1987,
And that was
when Philippe Mouret performed the first video laparoscopic cholecystectomy.
gallbladder removal.
Exactly. Removing a gallbladder using video technology. This was such a common procedure, but it usually needed a big, painful cut.
Right, the Kocher incision.
Yeah. And doing it through tiny keyholes, visualized on a screen for everyone in the operating room to see. Well, that was revolutionary.
Ah, the video was the game changer, making it visible to the whole team, improving collaboration, visualization.
That video element was absolutely transformative. And following that success, laparoscopic techniques saw really widespread adoption in the mid-1990s.
Okay.
That's when it truly moved from being a niche application to mainstream surgical practice.
So over 90 years, from the first experiment on a dog to widespread clinical reality, that's quite a timeline. And the material notes it's evolving, right?
Yes, it really highlights that MAS now is a multidisciplinary approach. It crosses traditional specialty boundaries,
Hmm.
general surgery, urology, gynecology, thoracic.
It's not siloed.
Not anymore. It's focused on serving the patient as a whole rather than just, isolated organ systems.
That makes perfect sense. The underlying technique, the principles can be applied across different parts of the body.
Hmm.
Speaking of techniques, the material outlines quite a few distinct approaches. Let's tour those. Let's try and understand the nuances of each one.
Right. Yeah, the text covers a good range. The most familiar one is probably laparoscopy.
Which is based on inserting a rigid endoscope, like a thin telescope, through a small tube or port
Sure.
into the peritoneal cavity, the main space in the abdomen.
Yes. And the material notes that the principles of pneumoperitoneum that's inflating the abdomen, usually with carbon dioxide gas, to create working space and visualization are absolutely central to this approach. We'll talk more about that later, but it's key.
Okay, pneumoperitoneum for the abdomen. What about the chest cavity?
That's thoracoscopy. Similar idea, introducing a rigid endoscope through an incision made between the ribs to access the thorax, the chest cavity. But this one requires specialist anesthetic support.
Ah, and that's for lung isolation, to work on one side.
Exactly. You need to collapse the lung on the side you're operating on to give you space, while the other lung is ventilated, typically using what's called a double lumen endotracheal tube.
Do you use gas insufflation, like in the abdomen, for thoracoscopy?
Generally not, according to the material. The rib cage itself is rigid, so it usually
Yeah.
maintains the space you need.
Okay.
However, it does mention specific instances, like removing certain mediastinal tumors or working on the diaphragm, where a low pressure of gas, maybe 5-8 millimilli Hg, might be used to help things along.
Interesting. So different cavities, similar principles, but adapted techniques. What about trying to hide the incisions even more, make them almost invisible?
Right. That brings us to single-incision minimal access surgery. This has seen periods of, well, quite strong interest.
Okay.
For the abdomen, it's often called single-incision laparoscopic surgery, or a less
else.
Yeah. All the instruments go through one single multi-channel port,
Right.
and it's typically placed right at the umbilicus, the belly button, sort of leveraging that natural scar.
And the perceived benefits are pretty obvious, right? A virtually scarless result cosmetically and potentially less pain and maybe reduced risk of port site hernias or bleeding because there are fewer holes.
That's the theory, definitely. And the hope. However, the material points out the technical requirements are higher. You need these specially manufactured multi-channel ports, and often you need instruments with articulating or bending tips.
Because everything's crowded coming through one spot.
Exactly. It makes triangulation harder.
And where has this approach, ASIL's, found its niche?
Mostly in less complex procedures, things like gallbladder removal, hernia repair. The text does mention that complex colon or rectal surgery can be done this way, but it's certainly not the standard approach.
And this technique has sparked some debate, hasn't it?
It has, yeah. The debate, as the material lays it out, really centers on whether the increased procedural difficulty.
It is harder for the surgeon.
Oh, definitely. That, plus the steeper learning curve and the higher direct costs of those specialized instruments and ports, does all that truly translate into a significant clinical benefit for the patient compared to standard multi-port techniques,
Which are already very good.
which are already highly effective and generally well tolerated. So it's that classic balance, pushing the technical limits versus demonstrable patient outcome benefits and, cost.
Always the trade-off.
The material also mentions uniportal thoracic surgery using a single incision for chest procedures. Apparently, it requires less specialized equipment than some other cutting-edge techniques and is common for minor procedures.
But for bigger lung operations.
For complex lung resections, it's noted as being technically more demanding than the standard multi-port approaches, which are generally well tolerated by patients anyway.
Okay, so a single incision is an option, but with definite trade-offs. What about going inside the body's existing openings? No external cuts at all.
Right. That's the realm of endoluminal endoscopy and natural orifice surgery. Notes. This involves using flexible or sometimes rigid endoscopes inside hollow organs or systems.
Like the gut, the airways.
Exactly. The GI tract, urinary tract, respiratory tree, or even blood vessels.
Like a standard colonoscopy or bronchoscopy, then.
Well, yes, those are standard endoluminal procedures. But the advances mean much more complex procedures are now done this way too. The text gives examples like endoscopic submucosal resection for really challenging colonic polyps.
Taking out tricky growth from inside the bowel.
Right, or transanal endoscopic microsurgery and even endobronchial laser resection for problems deep in the airways.
Okay, so advanced procedures within the tube. And notes takes it even further by going through the wall of an organ.
That's the key distinction, yes. Notes aims for truly scar-free external surgery. You go in via a natural orifice mouth, anus, vagina, and then you create a hole through the wall of an internal organ, like the stomach or the colon, to get access to body cavities like the abdomen or the pelvis.
Wow, that sounds incredibly complex and risky.
It is. And the material states that while it's been tested for accessing the pelvis, abdomen, and thorax, technical limitations and crucially safety concerns has significantly limited its adoption.
What's the main safety hurdle?
The principal issue that remains a major challenge is reliably and safely closing that puncture site in the organ wall from the inside. Sealing a hole in the stomach or the colon securely after you've gone through it has proven really problematic.
Yeah, I can absolutely see why that would be a potential showstopper. A leak there would be catastrophic.
Exactly. Plus, as noted, there are significant cost and training implications that further limit its widespread use right now.
Okay, so we've covered accessing cavities, going through single small holes, and using natural tubes. What about accessing spaces in the body that aren't natural cavities, like behind the abdominal lining?
That's paravisceral endoscopy. This approach accesses body planes or spaces without a natural cavity being present.
Can you give some examples?
Mediastinoscopy is one looking into the space between the lungs, and that's actually a relatively older technique, first performed back in 1959.
Wow, okay.
Others include retroperitoneoscopy, which accesses the space behind the main abdominal cavity.
For kidneys, maybe?
Yes, exactly. For procedures on the kidney, the aorta, or nerves like the lumbar sympathetic chain, which run back there.
Has technology improved these somewhat hidden space approaches?
Yes, definitely. The availability of novel videoscopes has significantly enhanced the visualization in these sometimes tight, difficult spaces.
Yeah.
That improves the safety and the accuracy of the dissection.
And where are these extraperitoneal, outside the main abdominal cavity approaches commonly used?
Well, for accessing those retroperitoneal organs, as we said, and increasingly for certain types of hernia repair.
Why hernia repair?
The material notes this can decrease morbidity because you avoid manipulating the visceral peritoneum, that delicate lining of the main abdominal cavity and its organs. Less manipulation, potentially fewer adhesions later.
Ah, okay.
Other examples mentioned include substacial endoscopic perforator surgery for varicose veins in the legs, and endoscopic harvesting of the saphenous vein from the leg for heart bypass surgery, getting that vein out with much less open dissection.
That's a really diverse set of applications. Shifting focus slightly again, what about joint surgery? That feels like a distinct area of minimal access.
It is, definitely. And arthroscopy and intra-articular joint surgery was actually one of the earliest applications of endoscopic techniques overall.
Going back to when? Earlier than laparoscopy.
It was first applied in the knee as early as the 1930s, and then Masaki Watanabe in Japan further developed techniques in the 1950s.
And now, I mean, it's incredibly common for joint problems, right? Knees, shoulders.
Oh, very common. Arthroscopy of the shoulder, wrist, elbow, and hip are absolutely standard procedures now.
Yeah.
And techniques are even being developed for smaller joints, like the temporomandibular joint in the jaw, or metatarsal joints in the foot.
It's remarkable how these minimal access concepts just spread and get adapted to different anatomical regions.
It really is.
Okay, finally, the material discusses hybrid minimal access surgery. What does hybrid mean in this context?
Hybrid essentially means combining different minimal access approaches within a single procedure. The text describes two main types. First, there's the totally endoscopic hybrid approach.
So combining, say, a flexible scope going down the throat with a rigid scope through the abdominal wall.
Yes, exactly. Or combining different scopes with other imaging devices to visualize and treat the area. In the abdomen, this could be combining laparoscopy with endoluminal endoscopy, maybe for complex gallstone issues or tricky colon polyps.
Right.
In urology, it might be used for things like pyeloplasty or even taking a kidney for transplant.
And you mentioned a chest example earlier involving navigation.
Yes, that's navigational bronchoscopy combined with video-assisted thoracoscopic surgery, VTS. So you use pre-op imaging to create a map of the airways.
Like a GPS for the lungs.
Kind of. You guide a bronchoscope to a lung nodule for biopsy, maybe place a marker, and then use that marker under X-ray guidance to help remove the nodule via minimal access chest surgery, VATS.
So imaging and different types of endoscopy all working together synergistically.
Precisely. And cardiovascular surgeons use similar hybrid approaches too, combining catheter-based techniques with minimal access surgery for things like valve replacements or placing stents.
What are the main benefits of these hybrid approaches?
The The materialists' improved visualization is a key one. This helps facilitate the procedure and allows techniques to be done via smaller incisions or minimal access, where previously only open surgery was feasible.
Is there a limitation?
The main one mentioned is that it often requires specialized hybrid theater facilities, operating rooms, equipped with advanced imaging and multiple types of endoscopic technology. This tends to limit these advanced approaches to larger tertiary centers.
Okay, that makes sense. That's one type of hybrid. What's the other one? The one that involves putting a hand inside.
Right. That's the open and endoscopic hybrid approach, commonly known as hand-assisted laparoscopic surgery, or HALS.
This is a well-established technique.
Hand-assisted, while still using the camera and gas. Yes, exactly. It involves making a small laparotomy incision, a small open cut, but bigger than a standard port site, just big enough to insert the surgeon's hand or forearm into the abdominal cavity.
Okay.
Crucially, you still maintain the pneumoperitoneum, the gas inflation, and you still use a laparoscopic camera and instruments through other standard ports.
So you get the visualization benefit of the camera, but you also get the tactile feedback, the feel of your hand.
That's the core idea.
Yeah.
The surgeon's hand can be used just like in open surgery, palpating organs or tumors to understand their texture and extent.
Feeling things you can't feel with instruments.
Exactly. Retracting structures gently and antromatically, identifying hidden blood vessels, doing blunt dissection with your fingers, and applying direct finger pressure to control bleeding while you get control of the vessel itself.
What are the proposed deficiencies with HLS? Why do it?
Well, advocates suggest it can offer technical and economic efficiency compared to a purely laparoscopic approach for certain complex cases. It might reduce the number of laparoscopic ports and instruments needed, potentially speeding things up.
And how does it stack up on the minimal trauma argument? Isn't putting a hand in more invasive?
That's the counter-argument. But the material notes that if the final specimen, say, a large piece of bowel that's been removed, needs a larger incision for extraction anyway.
Which it often does for big resections.
Right. Then performing the procedure, hand-assisted through a similar-sized incision, might not actually significantly increase the surgical trauma compared to a totally laparoscopic approach that still needed that same extraction incision at the end.
That's an interesting point. It sounds like it could be a good bridge technique for surgeons transitioning from open surgery.
That's also suggested. For surgeons primarily trained in open surgery, HALS may be easier and perhaps quicker to learn and perform safely than a totally laparoscopic approach for complex procedures, potentially enhancing patient safety during that transition period.
What about its future? Is it still widely used?
The text suggests that as newer generations of surgeons are trained predominantly in totally laparoscopic surgery right from the start, the use of HALS may diminish over time.
Makes sense.
However, it's emphasized that it remains a valuable part of the minimally invasive surgeon's armamentarium, another tool in the toolbox basically, to deploy when appropriate for the specific case and patient.
Okay. That was a really detailed tour through the different ways minimal access surgery is performed. Lots of variations. Now, let's get to the core question. Why has this field exploded? What are the really significant advantages unpacked in this material?
The material makes it crystal clear by drawing a strong contrast with traditional open surgery.
Right.
In open procedures, you need that large wound just to get the necessary exposure, to see and safely dissect. But that wound itself is a major source of morbidity, complication.
Like infection, pain.
Exactly. Wound infection, the wound splitting open, dehiscence, bleeding, hernias developing later at the site, and chronic pain from nerve damage or entrapment in the scar.
And all that pain from the wound leads to a slower, much harder recovery, doesn't it?
Precisely. Wound pain limits mobility. If you can't move easily, you're at higher risk of chest infections because you can't cough properly. You're at higher risk of your gut slowing down or stopping, Elias. And higher risk of blood clots, VTE, venous thromboembolism.
And the retractors used in open surgery.
They cause damage too. Those mechanical retractors used to hold tissues apart cause localized trauma and pressure, which can be just as painful, sometimes more so, than the incision itself.
So how does MAS avoid all this trauma?
Well, in laparoscopic surgery, for example, the working space and the tissue retraction aren't achieved by pulling tissue apart with harsh metal retractors. It's achieved by the pneumoperitoneum, that gentle, diffuse force of the gas inflation applied evenly over the abdominal wall.
Ah, it's a gentle push versus a hard pull. That makes so much sense.
It causes minimal trauma compared to those concentrated mechanical forces. And because the body cavities aren't widely open to the air.
You lose less heat and fluid.
Exactly. There's reduced morbidity from cooling and fluid loss by evaporation. Plus, The incidence of post-surgical adhesions, that internal scar tissue forming between organs, is also thought to be reduced because there's less direct damage and drying of the delicate serosal coverings of the organs.
And less handling of the internal organs themselves?
Significantly less,
Yeah.
particularly the gut. Less manual handling of the intestine compared to open surgery means less disturbance of its natural movement, its peristalsis.
Yeah.
That reduces the likelihood of adynamic ileus, where the bowel just stops working properly for a while.
So if you combine all these points, the advantages summarized in the material paint a very, very clear picture of the benefits.
They really do. It boils down to a decrease in wound size and all the related complications like infection, bleeding, hernia, nerve pain.
Right.
Decreased overall wound pain and trauma, which leads directly to improved mobility postoperatively, decreased heat loss during the procedure, and often actually improved visualization of the surgical field, thanks to the magnification and lighting from the camera, especially in deep cavities like the pelvis.
It's really easy to see why patients and surgeons embrace this so readily. The benefits for recovery are just profound.
Absolutely.
Now, while MAS clearly started in planned elective procedures, the material says it's also moving into more challenging areas now.
Yes, it highlights the increasing uptake of MAS methods for emergency surgical procedures, pushing beyond that initial focus on elective cases.
Really pushing the boundaries. What kind of examples are given?
Examples include using MAS for perforated viscous repair, like fixing a hole from a peptic ulcer with an omental patch, or washing out the abdomen in certain cases of perforated diverticulitis.
Okay.
Also, intrathoracic procedures like debridement for empyema, plus in the chest cavity, or managing collapsed lungs, pneumothorax, or bleeding into the chest, hemothorax.
And even trauma surgery.
Yes, the material notes that experienced surgeons are now using minimal access approaches for the initial assessment and sometimes even treatment in stable trauma patients. This requires significant expertise, obviously, but it demonstrates the growing confidence and capability in the field.
So from simple elective gallbladder removals to complex emergency repairs and even trauma assessment, that really underscores how far this field has come.
It does.
But as we touched on earlier, it's not without its difficulties. Nothing's perfect. What are the key limitations of minimal access surgery outlined here?
Right. The material addresses the limitations, quite frankly. It frames them as challenges where the field continues to evolve and technology is definitely helping, but where some fundamental difficulties still exist.
What's the first major technical hurdle mentioned?
Probably the lack of three-dimensional vision. Standard endoscopic systems give you a 2D flat image of the operative site on the monitor.
Right, like watching TV.
Exactly. And that makes judging depth and spatial relationships really difficult. It forces the surgeon to operate within the text calls a completely new anatomical landscape compared to the familiar 3D view you get in open surgery.
I can imagine that would be incredibly disorienting, especially when you're first learning.
Oh, it is. The material really stresses that for novices, this creates significant hand-eye coordination issues, and it underlines the critical need for dedicated simulation training and proper mentoring to achieve competence safely. You can't just jump into it.
Are 3D systems available to help with this?
Yes, 3D imaging systems do exist for laparoscopy and thoracoscopy, but the source notes, they're currently expensive and not yet commonplace.
Why not, if 3D is better?
Well, while some offer true stereoscopic vision, the material suggests that many surgeons don't feel they provide sufficient technical enhancement yet to justify the high cost and added complexity for most procedures.
Are there any downsides mentioned to the current 3D tech? Practical issues?
Yes, they mentioned potential ergonomic issues like headaches for the surgical team. Some systems require wearing special glasses, which can be cumbersome. Plus, there can be drawbacks like reduced image brightness compared to 2D.
So not quite perfected yet for straight stick.
It seems not universally adopted anyway. The material does note that this is an area where robotic systems, which often integrate high-quality 3D vision as standard, have seen perhaps greater clinical uptake compared to straight stick endoscopic 3D systems.
Okay, so 3D vision is a challenge being addressed by technology, but maybe not fully solved for all systems yet. What's another limitation?
Increased operative time. Minimal access surgery can often be more technically demanding and therefore slower to perform than the equivalent conventional open procedure, especially during the learning curve or for complex cases.
And if the procedure becomes too difficult or unsafe to continue minimally invasively?
Then you convert. The material is very clear on this. Occasionally, a minimal access operation proves so technically challenging or unsafe that both the patient and the surgeon are better served by converting to an open procedure.
And that's not seen as a failure.
It explicitly states that the decision to convert is not a complication. It usually represents sound surgical judgment, prioritizing patient safety above all else.
That's a really important point, knowing when to switch strategy. But prolonged operating times themselves carry risks, don't they, even if you don't convert?
They absolutely do. Extended anesthetic and operative times can negate some of the benefits of MAS. They increase the risk of respiratory complications, potentially wound complications if conversion happens late, and issues like nerve damage from positioning, compression neuropathy, and blood clots, VTE.
Okay. Another significant hurdle must be managing bleeding when you're working through keyholes.
Yes, control of bleeding and hemostasis is a major challenge in minimal access surgery. Blood absorbs light and just obscures the field, reducing image quality dramatically. This is noted as being particularly challenging with robotic systems sometimes.
How do surgeons cope with that sudden loss of clear vision when bleeding occurs?
It requires significant experience and skill. The text states that an experienced surgeon may be able to manage some bleeding endoscopically, but it's highly reliant on having an equally experienced assistant who can optimally position the camera to maintain the best possible view, constantly clearing the lens.
It sounds stressful.
It can be. And the risk is that a situation of initially controlled bleeding can rapidly escalate, forcing an emergency conversion to open surgery, which, as we said, undoes the minimal trauma benefit and carries its own risks.
Are there specific tools that help control bleeding in MAS?
Yes, technology helps here. Advanced electrosurgery devices, diathermy, and laser technology offer improved precision for cutting and sealing vessels. Ultrasonic dissection devices and tissue fusion devices are also evolving.
What do they do?
They use different energy forms, like ultrasound or pressure and heat, to cut and seal tissue simultaneously. They often combine multiple functions, which can reduce the number of instrument exchanges needed and provide a cleaner, smoke-free field. That helps with both dissection and stopping bleeding, and can potentially reduce operative times too.
We talked earlier about not being able to feel the tissue in the same way with instruments. Is that listed as a limitation?
Yes. The loss of tactile feedback is highlighted as a significant limitation. It's perhaps less pronounced with straight stick endoscopy, where you have some direct connection, compared to robotic systems where the instruments are controlled completely remotely.
Like playing a video game, almost?
In a way, yes. But it's still an issue even with straight sticks. It's an active area of research. Things like haptics and biofeedback systems are being developed, trying to replicate that sense of touch electronically.
Is there anything currently used that offers a kind of visual compensation for that lost sense of touch? Something you can see instead of feel?
The material mentions laparoscopic ultrasonography. Now, it's not tactile feedback, obviously, but it provides a visual representation of structures that you would normally feel or palpate in open surgery.
Like finding lumps or stones?
Exactly. It helps with accurate localization, for example, assessing lymph nodes in cancer surgery to see if they look suspicious, or exploring the bile ducts to check for hidden stones.
Okay, so challenges with vision, time, bleeding control, and touch. What about getting larger pieces of tissue out once you've freed them up inside?
That's the challenge of tissue extraction. Removing larger specimens, like a section of lung after a lobectomy, or a segment of colon after a colectomy, can be difficult through small holes.
Right.
It often necessitates enlarging one of the port incisions significantly, sometimes making quite a large cut, which can increase the overall surgical trauma of a procedure otherwise performed through tiny holes. It negates some of the minimal aspect.
What about using morcellators to break up the tissue inside?
The text mentions morcellators can be used for benign tissue, but notes they disrupt the gross morphology, the structure of the specimen. That makes them unsuitable for procedures involving malignancy, where the pathologist needs to examine the tissue intact to assess margins and spread.
So for cancer surgery, you need to get it out whole. How is extraction typically managed then for larger specimens?
Usually by carefully enlarging one of the port incisions just enough to remove the intact specimen without disrupting it, often placing it in a protective bag first.
Are there strategies to minimize the trauma of that extraction?
Yes, the material mentions strategies like removing lung specimens via an incision below the sternum, subxiphoid, to minimize intercostal nerve pain compared to enlarging an incision between the ribs, or potentially extracting abdominal specimens via a natural orifice, like the vagina or rectum in some cases, though these alternative extraction methods have their own potential complications, like hernia formation or injury to structures.
And there were initial concerns, particularly with cancer surgery, about accidentally spreading tumor cells to the port site during extraction.
Yes, port site tumor implantation or localization was a significant early concern. It raised questions about the safety of laparoscopic cancer surgery initially.
Have those concerns been addressed?
Largely, yes. The material states that large clinical trials have now shown these concerns are significantly minimized by using appropriate tissue handling techniques.
Like using bags.
Exactly. Like isolating tumors within a protective endoscopic bag before removal, irrigating the area thoroughly, and protecting the edges of the extraction site during the procedure. Proper technique makes it very low risk now.
Okay. Finally, the impact on the wallet. Cost. Was MAS initially more expensive?
Yes, this was a significant initial limitation. High consumable costs, all those single-use instruments, energy devices, ports, specimen bags, combined with factors like the surgeon's learning curve, longer operating times initially, and potentially higher conversion rates, did make early MAS procedures more expensive than traditional open surgery.
Is that still the case for standard MAS, like laparoscopy?
For standard straight-stick endoscopic surgery like laparoscopy and thoracoscopy, the material indicates this is largely no longer the case for many common procedures.
How so? The instruments are still pricey.
They are. But while the direct consumable costs remain higher, the improvements in patient outcomes, especially the shorter hospital stays, and the overall increase in procedural volume and efficiency, have made many minimal access procedures cost-effective overall when you consider the whole episode of care, not just the OR costs.
So, the downstream savings often outweigh the upfront tool costs for established techniques.
Often, yes. It balances out or even comes out ahead. However, the material highlights that the cost equation is complex. Factors influencing it include that balance between direct consumable costs versus the benefits and outcomes and length of stay.
And robotics.
Robotic surgery still remains significantly more costly than straight-stick MAS or open surgery in most analyses. Increased operating time during the learning phase also adds expense for any new MAS technique. And shared use of expensive equipment, like a robot.
Good for the hospital budget, maybe.
Right, increases cost effectiveness for the institution, but it can reduce individual surgeon access, potentially prolonging their learning curve, which has a knock-on cost effect.
It's complicated. The last limitation listed is a more general one, reliance on new technologies.
Yeah, this is just inherent to a field driven by innovation. If the specialized equipment, the camera stack, the light source, the insufflator, specific instruments fails or isn't available or isn't properly maintained, the procedure simply can't be performed minimally invasively, or at least not safely. You need the tech to work.
Okay, that gives us a very clear picture of the technical, logistical, and economic challenges that exist alongside the benefits. This material then introduces a major technological step aimed at tackling some of these very limitations: robotic surgery.
Indeed. Robotic surgery was developed explicitly, really, to assist surgeons and address some of those inherent difficulties of straight-stick endoscopy we've just been discussing.
How does the source define a surgical robot? What is it, fundamentally?
It's defined as a mechanical device capable of performing automated physical tasks based on either human supervision, a predefined program, or even general AI guidelines, potentially.
And in surgery, what do they mostly do?
In surgery today, they primarily act either as automated camera holders or, more commonly now, as telemanipulators, providing that human-machine interface where the surgeon controls robotic arms.
And what's the key advantage they offer over just using straight sticks?
The material states that the reduced degrees of freedom, that limited range of motion you get with straight instruments, and the often difficult ergonomic positioning for the surgeon in straight-stick endoscopy can limit precision and cause fatigue. Robotic systems are designed specifically to help overcome these issues.
What are the two main categories of surgical robots described in the material?
Yeah, first you have teleoperated master-slave systems. This is the most common type you see today, like the Da Vinci.
Master-slave.
Yeah. The surgeon, the master, sits at a console and controls the robot, the slave, and its instruments via a computerized platform. This link is usually within the same operating room complex.
But it could be remote.
Potentially, yes. The text mentions the possibility of remote operation, operating on a patient from another country, remains rare in practice. but it is technically established. The capability exists.
Okay, teleoperated is one type. What's the second?
The second category is active or semi-active systems. These are typically image-guided or pre-programmed.
So the robot does more on its own.
In active systems, yes, the robot performs a pre-programmed surgical task, guided by imaging and real-time data feeds. Semi-active systems are partly pre-programmed and partly driven by the surgeon during the procedure.
Interesting, the robot doing some of the actual work itself based on a plan. Let's look briefly at the history of surgical robotics mentioned here.
Right, the first clinical robotic procedure noted is actually a CT-guided brain biopsy way back in 1985, using a system called the PUMA 560.
Okay.
Another early example was RoboDoc, which was an active robot used in orthopedics for precise bone preparation and hip replacement surgery. It was valued for its high accuracy.
But those were largely superseded by laparoscopy itself.
Yes, the material notes these early active robots were largely overtaken by the rapid adoption of laparoscopy and thoracoscopy in the 90s and 2000s, which offered different kinds of benefits. However, systems designed specifically for endoscopy started emerging then.
Like the automated camera arm.
Exactly. The ASOP system, developed in 1992, was an automated robotic arm for holding and controlling the endoscopic camera, often controlled by voice command. Apparently it saw quite wide use.
And then came a full robotic system.
Yes, that was followed by the ZUS robot in 1996.
Tell me about ZUS. What was it like?
ZUS was a master-slave teleoperated system. It had 3 arms, 1 for the camera, 2 for instruments. The surgeon controlled it from a remote console separate from the table.
Did it have special features?
Yes, key features included motion scaling, where large hand movements were translated into smaller, very precise instrument movements inside the patient, and tremor correction, filtering out the surgeon's natural tremor. This made it suitable even for delicate microsurgery.
And ZUS had some historical firsts associated with it.
It did. It was used for the first fully endoscopic robotic procedure, a fallopian tube reanastomosis in 1998, and most famously, the Lindbergh operation in 2001.
The transatlantic surgery.
That's the one. A surgeon in New York performed a gallbladder removal on a patient in Paris, France, using the ZUS system. It really proved the technical feasibility of long-distance robotic surgery.
What happened to ZUS?
ZUS was discontinued in 2003 after its developer, Computer Motion, merged with its main competitor, Intuitive Surgical.
Ah, which brings us neatly to the dominant system in the field today.
Exactly, the Da Vinci surgical system. First approved by the FDA in 2000, it has really dominated the current era of surgical robotics.
What gives it that dominance? What are its key features?
The material highlights several key advantages. Its high-quality 3D surgical vision, the precision of its endowrist instruments.
The ones that bend like a wrist.
Yes, they have articulating joints mimicking the human wrist, giving much more dexterity than straight sticks. Plus, it has built-in tremor reduction, motion scaling, and vastly improved ergonomics for the surgeon compared to standing for hours doing laparoscopy.
And the Da Vinci itself has evolved over time.
Oh, significantly. From the initial 3-arm system, it progressed through the Da Vinci S, then the C, and then the G models, each introducing improvements in vision, instrumentation range, and integrated features like fluorescence imaging capabilities.
And the latest development.
More recently, they have launched the Da Vinci SP, which stands for single port. It's a system designed to bring multiple wristed instruments and a wristed camera through just one single small incision, aiming to enhance dexterity even further while minimizing the trauma from multiple port sites.
Okay, so that's the dominant player and its evolution. Let's delve deeper now into the power of robotics. How do these features actually translate into real advantages over traditional straight stick MAS?
Well, a major advantage discussed is vision. Robotic systems, particularly the Da Vinci, typically offer high-definition 3D imaging.
So true depth perception.
Yes, true stereoscopic vision with depth perception. This is a significant improvement over the standard 2D view of endoscopy, and it greatly enhances the surgeon's visualization of delicate tissue layers and important anatomical structures.
And the surgeon controls the view.
Yes, in multi-port systems, the rigid endoscope, often angled at 30 degrees to look around corners, is controlled either directly by the surgeon at the console or sometimes by a trained bedside assistant following commands. The surgeon usually has a reference horizon displayed on screen to help maintain orientation within the body cavity.
And the single port system's camera.
The newer single-port Da Vinci SP uses a wristed camera that can articulate, combined with the wristed instruments. This allows for triangulation approaching the target tissue from different angles, all coming through that single small incision, which is quite remarkable.
So that directly addresses the 2D vision limitation we discussed as a major hurdle for straight stick MAS.
It really does.
What about the physical manipulation of tissues? The dexterity?
That's where maneuverability, motion scaling, and tremor suppression come in. The robotic wrist on the instruments provides exceptional dexterity, with up to 7 degrees of freedom of movement, mimicking or even exceeding the human wrist's capability inside the body.
Where is that extra dexterity most useful?
It's especially beneficial in confined spaces where conventional, straight, rigid instruments are very difficult to maneuver, places like deep in the pelvis or during transoral surgery through the mouth.
So it potentially enables minimal access for more complex procedures that were previously only possible via open surgery.
Precisely. The increased dexterity allows surgeons to perform more complex dissection and suturing using a minimal access approach, where conventional laparoscopy might have been too difficult, too slow, or even impossible.
And motion scaling. Remind me what that does.
Motion scaling is also key. It scales down the surgeon's natural, larger hand movements at the console into smaller, incredibly precise movements of the instrument tips inside the patient. You can set the ratio, like 3.1 or 5.1.
And it filters out any natural human hand tremor.
Yes, the computer actively filters out the surgeon's natural physiological tremor. This results in rock-steady instrument tips, enhancing surgical precision, which is absolutely critical for delicate dissection near vital structures and for accurate suturing.
You mentioned ergonomics as a major benefit earlier. How much better is it for the surgeon?
It's a substantial improvement, really. Straight stick laparoscopy, while great for the patient, often puts significant physical strain on the surgeon.
Backache, neckache.
Exactly. Back, neck, shoulder, arm discomfort, especially during long, complex cases or when operating on patients with challenging anatomy, like morbid obesity requiring very long instruments and awkward reaching.
And robotics changes that setup entirely.
For master sleeve systems like Da Vinci, yes. The surgeon operates while seated comfortably at an ergonomic console, often located away from the operating table itself. This console can be adjusted to the surgeon's individual preference, significantly reducing physical stress and fatigue during long operations.
Does being remote at the console have any downsides in the OR environment?
Well, the enclosed console environment provides a degree of isolation, which can definitely aid concentration, but it does reduce the surgeon's direct awareness of non-verbal cues from the bedside team, the assistant, the scrub nurse, the anesthetist.
So communication is key.
Absolutely paramount. It emphasizes the necessity of strong team training, very clear verbal communication, and established protocols throughout any robotic procedure.
Is there potential for robotics to compensate for patient movement, like operating on a beating heart without stopping it?
The material mentions motion compensation as a potential future benefit, although it's not yet commonplace clinically. The idea is for the robotic system to track and actively compensate for the movement of the target organ in real time.
Allowing surgery directly on a moving target.
Exactly. The text specifically cites beating heart cardiac surgery procedures as a potential application, by potentially removing the need to stop the heart with cardioplegia drugs or use aortic cross-clamping.
Which has its own risks.
Right. Combining motion compensation with robotic dexterity could significantly reduce the postoperative inflammatory response associated with bypass machines and improve morbidity for certain cardiac procedures.
That truly sounds like the next frontier. Okay, we've heard the compelling advantages of robotics, how it addresses some key limitations of straight stick MAS. What about the disadvantages? Nothing is perfect, right? What are the downsides?
Well, the first and probably most discussed disadvantage remains cost. Robotic surgery is significantly more expensive than other minimally invasive options, and certainly more than open surgery.
Even with higher volume and shared use, helping to amortize the initial purchase.
Yes. Well, increasing the number of procedures and sharing the system across multiple surgical specialties can help an institution offset the very high initial purchase cost of the robot itself.
Which is millions.
Yes. The consumable costs of the specialized instruments, drapes, and accessories, many of which have limited uses, or are single-use and require frequent replacement, remain consistently high.
And does it always lead to better outcomes or shorter stays compared to other MAS techniques?
That's a key point. While robotic surgery often reduces hospital stay compared to equivalent open surgery, The material notes it's frequently difficult to demonstrate a significant additional reduction in length of stay or major clinical outcomes when compared specifically to other existing minimally invasive techniques like standard laparoscopy for many procedures.
So often much more expensive without a clear, quantifiable additional benefit in length of stay or major complications compared to standard laparoscopy for common operations.
That's a key point the material implies for many procedures, yes. Although the benefits might be clearer or more significant in specific, highly complex cases, or in specialties where straight stick techniques are particularly challenging ergonomically or technically, like radical prostatectomy.
Okay, cost is a big one.
Yeah.
What else?
Another significant disadvantage is the learning curve.
Is it steeper or longer than learning standard laparoscopy?
The material notes it definitely requires increased operating time initially and a dedicated, structured learning curve to establish a safe and efficient robotic surgical program. While some surgical specialties report shorter learning curves for robotics compared to the early days of laparoscopy, it's highly variable. It depends on the complexity of the procedure, the individual surgeon's aptitude, the quality of training, and the institutional support.
And that issue of shared access affects the learning curve too.
Yes, as we discussed with cost, shared use of an expensive robot, while fiscally sensible for the institution, can limit individual surgeon access, meaning fewer cases, which can potentially prolong their personal learning curve and time to proficiency.
And despite its advantages, is robotic surgery adopted everywhere for every possible procedure?
Well, there is widespread adoption across many surgical specialties, now general surgery, cardiothoracic, urology, gynecology, ENT, orthopedics, pediatrics, even microsurgery. However, the material points out that current robotic surgery remains primarily focused on operations conducted within the hospital setting.
Despite the technical ability for remote surgery, like the Lindbergh operation showed.
Right, that operating across countries scenario is still much more a proof of concept or for very niche applications rather than routine clinical practice. The vast majority of robotic surgery happens with a surgeon in the same building, if not the same room.
Okay. Given Da Vinci's long dominance, is the field seeing more competition now? What does the evolving landscape look like with new systems emerging?
Yes, absolutely. The material details the emergence of several new robotic systems entering or preparing to enter the market. This is creating more competition, offering potential alternatives, and perhaps aiming to address some of the limitations or the high costs associated with the incumbent system.
Can you give some specific examples mentioned?
Sure. Intuitive Surgical themselves, the makers of Da Vinci, launched the Da Vinci X system in 2017. It's positioned as a somewhat lower cost entry point into their portfolio, retaining many features of the higher-end Xi system, but perhaps with less flexibility for complex multi-quadrant abdominal surgery. Then there's a Korean company called Mir, which gained a license in 2017 for their ReVO system. It's described as a four-arm robot on a single cart, with an open vision cart design and 3D HD vision requiring glasses.
And wasn't there one focused on modularity and mimicking the human arm?
That sounds like the Versius system from the UK-based company CMR Surgical. It received its CE mark in Europe in 2019. It uses individual cart-mounted robotic arms designed to mimic the human arm's range of motion, allowing for more flexible port placement on the patient. It also provides 3D HD vision with glasses.
And one designed specifically to bridge the gap with existing laparoscopic tools.
Ah, that would be the Senhance system, which got its CE mark back in 2016. This system uses independent cart-mounted arms. But critically, it's designed to accept reusable, non-wristed instruments that can be inserted through standard laparoscopic trocars.
So, potentially lower consumable costs and easier hybrid procedures.
That seems to be part of the strategy, yes. Trying to integrate more easily with familiar tools and potentially be more cost-effective on the instrument side. It also offers 3D HD vision with glasses and features like eye-tracking camera control.
So definitely more players entering the market.
Yes, and the material also mentions systems that were under development or recently launched at the time of writing, like the Medtronic Hugo RAS system, designed to be modular, potentially lower cost, and upgradable. And Verve Surgical, the collaboration involving Johnson & Johnson and Google's Verily, was noted as working to evolve beyond the current master-slave model, towards incorporating more autonomy and machine learning, although that seemed to be in earlier stages.
Beyond the standard master-slave approach we mostly see, are there other types of direct or hybrid robotic concepts emerging?
Yes, the text briefly touches on direct robotic systems and hybrid robotic surgery concepts that go beyond the teleoperated model. These systems might incorporate features like active tremor suppression for handheld instruments, active guidance to keep instruments on a planned path, force control to limit tissue damage, or even haptic feedback relayed back to the surgeon.
What advantages might these offer?
Their potential benefits could include reducing the need for skilled human assistance during certain parts of the procedure, or perhaps providing remote guidance or proctoring from expert surgeons to less experienced ones in real time. Different ways of leveraging robotic assistance.
It's clear the robotic landscape is dynamic, with new players and new technological approaches entering the fray. Very exciting. Now, let's shift back to the patient's journey and the practicalities surrounding the surgery. Even with minimal access, careful preparation is absolutely key. What does the material say about perioperative planning for MAS?
It really stresses the fundamental importance of meticulous preoperative management. Even though patients might have shorter hospital stays, proper preparation is absolutely essential for minimizing morbidity, minimizing complications.
What does that involve?
It involves recognizing patient-specific or procedure-specific factors that could complicate a minimal access approach, increase risks, or even necessitate planning for a likely conversion to open surgery from the start.
What kind of patient assessment factors are vital to consider?
Well, assessing overall fitness is crucial. Patients must be fit not only for general anesthesia, but also specifically fit enough to withstand a potential open conversion if it becomes necessary intraoperatively.
Okay.
Identifying any coagulation disorders is critical because the limited hemostasis options endoscopically make bleeding particularly dangerous. Any history of bleeding problems needs careful evaluation. Prior surgery in the same anatomical region is also vitally important to note.
Because of scar tissue.
Exactly. Potential scars and adhesions can significantly increase the technical difficulty of accessing the area and dissecting safely. It helps predict a potential need to convert. Previous oncological treatment, like radiation therapy, can also create a hostile scarred environment. In such cases, it's important to set and clearly communicate an appropriate, perhaps lower threshold for conversion with the patient and the team beforehand.
And general health factors that might impact MAS.
Yes, routine assessment of cardiac function, like arrhythmias, lung function, current medications, especially blood thinners, and allergies is required. Severe respiratory conditions like COPD or significant ischemic heart disease can sometimes be relative contraindications to minimal access approaches, mainly due to the potential physiological stresses of anesthesia and pneumoperitoneum.
Does the patient's body shape or size matter for MAS?
Yes, body habitus is important. Moderate obesity is usually manageable with standard MAS techniques, but morbid obesity may require specialized longer instruments, different port placement strategies, or even specific bariatric surgical tools.
And very thin patients.
Conversely, patients with a very low BMI or small build can sometimes present challenges for port placement, especially with the larger footprint of some robotic systems. Just fitting the arms around them can be tricky. Skeletal deformities like severe kyphosis or scoliosis can also cause positioning difficulties on the operating table and might impact post-op recovery, particularly things like lung function and mobility.
What about preventing blood clots during and after these procedures? Is it different for MAS?
Thromboprophylaxis is pretty standard, similar to open surgery protocols. Risk factors specific to MAS can include certain patient positions like steep reverse Trendelenburg, head up, feet down, which can cause blood to pool in the legs, and potentially prolonged operative times in complex cases.
So what are the standard measures?
Standard measures usually include subcutaneous low molecular weight heparin injections, antithromboembolic stockings, TEDs, and pneumatic calf compression devices used during the surgery itself. Managing patients already on anticoagulants or aspirin needs careful risk-benefit assessment based on established protocols when to stop, when to restart.
Were things like urinary catheters and nasogastric tubes always part of MAS care? Have practices changed?
In the early days of MAS, routine bladder catheterization and placing nasogastric tubes were often common recommendations. However, the text notes that the shift towards enhanced recovery after surgery, ERAS protocols, has led most surgeons to omit these routinely now.
Why? What are the benefits of avoiding them?
Avoiding routine tubes favors faster mobilization, earlier oral intake, and generally less discomfort for the patient. This has shown benefits in reducing length of stay and overall morbidity.
But you still need an empty bladder.
Oh yes, it is still absolutely essential though to ensure the patient is appropriately fasted and has an empty bladder before creating pneumoperitoneum, especially in abdominal cases, to avoid injury. Catheters and NG tubes are rarely used in non-abdominal MAS anyway.
And critically, the conversation before surgery, informed consent.
Absolutely crucial. The patient must have a full understanding of the nature of the proposed procedure, the potential risks involved, both general and specific to MES, and the alternative treatment options available, including non-surgical ones, if applicable.
And they need to understand about conversion.
Vitally important. They must specifically understand the possibility and the potential reasons for conversion to an open operation during the procedure. The material suggests that well-prepared explanatory booklets can be helpful resources to supplement the discussion.
What kind of complications should be mentioned?
Surgeons should discuss common, usually minor complications like shoulder tip pain from the gas or minor surgical emphysema, air out of the skin, but also the rare but potentially serious ones like inadvertent organ injury, bowel, bladder, vessels, or diathermy burns. It's also important to address any specific patient concerns, particularly regarding newer technologies like robotics, if that's being used.
So, thorough patient assessment, recognizing potential challenges ahead of time, and crystal clear communication are paramount before the procedure even begins.
Absolutely. Preparation is key.
Okay, let's move into the operating room itself now. What about the theater setup and tools? What's important there for MAS?
The OR environment is critical for efficiency and safety in MAS. Modern operating theaters designed specifically for minimal access surgery often feature things like ceiling-mounted movable booms for equipment to keep the floor clear.
Less clutter.
Right. High-resolution monitors, often HD or even 4K, now strategically placed so the whole team can see clearly. Reliable CO2 supply systems for insufflation, and integrated audiovisual equipment for recording or transmitting images.
Why is image quality emphasized so much?
Image quality is absolutely vital for successful and safe minimal access surgery. You're operating based entirely on what you see on that screen. Advances in camera chip technology and lens design allow for smaller camera heads while maintaining excellent resolution and light sensitivity. Features like autofocus and improved CCDs help optimize image quality in the often challenging variable light conditions inside a body cavity.
And the human element teamwork in the OR.
Essential. Highly efficient teamwork among the entire surgical team, surgeon, assistants, scrub nurse, anesthetist, circulating nurse, is paramount for quality surgery and for safe, timely turnover between cases.
And especially important for robotics.
Particularly true in robotic surgery, yes. Because the surgeon is at the console, often physically separated from the bedside team, clear, concise verbal interaction is absolutely critical. Robotic teams must specifically rehearse protocols for both planned events, like docking the robot, and emergency scenarios, like rapid undocking for conversion.
Okay, setup and teamwork are key. Moving to general intraoperative principles, the material points out that minimal access procedures often have a unique sequence of steps. They can be quite different from their open counterparts, right?
Yes, the workflow can be very different.
Such as how you first gain access to the body cavity.
Exactly. The methods for safely establishing access and creating the pneumoperitoneum in abdominal cases are key first steps, and there are different techniques for doing that safely. Managing potential surgical scars and adhesions from prior operations is also a major intraoperative consideration.
How do you deal with adhesions you expect from previous surgery?
Well, preoperative assessment helps anticipate where adhesions might be dense. For redo surgery, the initial trocar insertion can be particularly hazardous. It should ideally be done using a mini-open technique, making a small cut and dissecting down under direct vision to ensure safe entry into the cavity without injuring underlying structures like bowel stuck to the abdominal wall.
So a small open cut just to get the first port in safely under direct view.
That's often the safest way in a scarred abdomen, yes. Once inside with the camera, the surgeon can sometimes use a fingertip through that initial port site to gently feel and confirm clear entry, or carefully sweep away flimsy adhesions obstructing the view.
Can you use the camera itself?
Yes. The endoscopic camera itself, used carefully as a blunt dissector, can sometimes help tease adhesions apart to find the correct operative plane. Experience helps the surgeon differentiate visually between thick, vascular adhesions that need careful handling or avoidance, and thinner vascular ones that can often be safely divided with energy devices or scissors.
What specific considerations come up when operating on obese patients during the procedure itself?
Obese patients present specific intraoperative challenges. Port locations may need to be adjusted, often placed higher or more laterally than usual. Longer instruments and trocars are usually required to reach the target anatomy. Recognizing this during preoperative planning is important so the right equipment is available. Also, the operating table's weight and dimension limits must be checked, and specialized bariatric operating tables may be necessary for very large patients. Positioning can also be more challenging.
So, adapting the plan and technique based on the individual patient's anatomy and history is absolutely key throughout the operation. Yeah. Now, let's talk about when things don't go according to plan, operative problems and complications.
Right. The material lists several potential problems. One major category is intraoperative perforation or vascular injury. Inadvertently injuring an organ like the bowel or bladder or a blood vessel is a significant risk in any surgery, but perhaps especially challenging to manage in MES.
Why is it more challenging in MAS?
Well, the injury might be minor and manageable endoscopically, but it could be significant enough to require immediate emergency conversion to open surgery. And as we discussed, that conversion itself takes time.
Time when the patient might be bleeding or unstable.
Exactly. The time required to convert, particularly if it's an emergency conversion for major bleeding or a large bowel injury, can exacerbate blood loss, contamination, and hemodynamic instability that might not have occurred to the same degree had the injury happened during an open procedure that was already underway.
So prevention is key.
Absolutely. The text emphasizes that prevention through surgeon experience, thorough education, meticulous preparation, appropriate patient selection, and good technique is vital. The entire surgical team must recognize its limitations and continuously assess the progress of the operation, being ready to change course if needed.
What is identified in the material as the most common reason for having to convert a minimal access procedure to open surgery?
Bleeding. Uncontrolled or difficult to control bleeding is cited as the most frequent cause of conversion.
And why is bleeding such a challenge specifically in MAS?
As we touched on, blood obscures the field of vision much more dramatically than in open surgery. It absorbs the light from the endoscope, significantly reducing image quality. This is noted as being particularly an issue sometimes in robotic surgery where the camera view can degrade quickly.
How is bleeding managed endoscopically if it occurs?
It requires significant experience and skill, as well as an experienced assistant who can keep the camera lens clean and positioned optimally. An experienced surgeon may be able to manage a certain degree of bleeding endoscopically using various techniques.
Are there specific patient factors that increase the risk of bleeding during MAS?
Yes, conditions like underlying liver disease, which affects clotting factors, acute inflammatory conditions like cholecystitis or diverticulitis, where tissues are fragile and vascular, patients taking anticoagulants or antiplatelet drugs, or those with pre-existing, sometimes undiagnosed, coagulation defects. These all need careful consideration and sometimes specific preoperative preparation or even contraindicate an MAS approach.
If a large vessel injury occurs during MAS, what's the immediate plan according to the material?
Immediate assessment of the magnitude and type of bleeding is critical. Paramount importance is placed on clear and immediate communication to the entire theater team, especially the anesthetist, the moment significant bleeding is identified.
Convert quickly.
The text advocates for a relatively low threshold for early conversion to open surgery in the face of major vessel injury, depending on the team's expertise and the situation. Early control by any means necessary is the priority.
How is control attempted endoscopically first, if deemed feasible?
If the bleeding vessel can be clearly identified, control might be attempted with endoscopic clips, stapling devices, or advanced energy devices, like bipolar or ultrasonic sealers. Suturing is possible laparoscopically or robotically, but it's technically complex and time-consuming, especially under pressure.
What if you can't see the exact source?
If the specific bleeding point isn't identified immediately, the first step is immediate compression using a blunt instrument, a folded swab introduced through a port, or even pressure from an adjacent organ. Good suction and irrigation are then needed to try and clear the field and identify the source once pressure is briefly released. An extra port might need to be inserted quickly to facilitate this. But the text is emphatic. There should be no undue delay in converting to an open procedure when bleeding is uncontrolled or the situation is deteriorating. Patient safety comes first.
And with robotics, converting for bleeding adds another layer of complexity, right? Getting the robot out of the way.
Yes. In robotic surgery, some or all of the robotic arms may need to be urgently undocked from their ports to allow the surgeon and assistant's direct bedside access. The bedside assistant must be well trained and confident in performing this undocking procedure rapidly and safely. Sometimes one robotic arm or an instrument through an assistant port can be used to maintain pressure on the bleeding point while the main robot is undocked.
What about more general oozing or bleeding from the surface of organs, not major vessels?
That can happen too. Excessive retraction, especially with instruments that have small grasping surfaces like some robotic graspers, can tear the delicate surface, serosa or capsule, of organs like the liver or spleen. The material suggests using rolled swabs held within the grasper jaws to provide a larger, less traumatic surface area for retraction. For surface oozing, topical hemostatic agents.
Like sponges or glues.
Exactly. Things like Surgicel, oxidized cellulose, fibrin glues, or special clot-promoting strips can be very useful. They can be applied directly to the bleeding surface, for instance, onto the raw bed of the liver after gallbladder removal.
And what about bleeding specifically from the small port sites themselves? Can that be a problem?
Yes, trocar site bleeding can occur, usually from small vessels in the abdominal wall. It's typically managed with localized diathermy applied carefully around the trocar, or just direct pressure with the trocar itself, held in place for a few minutes. Occasionally, a larger vessel, like the inferior epigastric artery in the abdominal wall, or an intercostal artery in the chest wall, can be injured during trocar insertion.
How is that managed?
Hemostasis is usually achieved by direct pressure followed by suturing. Devices like the endoclose allow sutures to be placed through the abdominal wall under laparoscopic vision to catch the vessel. If the specific vessel is hard to identify, sometimes mass ligation around the entire port site using figure-of-8 sutures passed through the full thickness of the wall is necessary. Another trick mentioned is inserting a Foley balloon catheter through the bleeding trocar site, inflating the balloon inside, and applying gentle traction to tamponade the bleeding from within. Bleeding from the falciform ligament near the umbilicus can sometimes be managed by percutaneously inserting a suture loop around it under vision.
Managing bleeding endoscopically sounds incredibly demanding. It clearly requires significant experience, good assistance, and the right tools. What about dealing with blood clots that have already formed in the field?
Yes, evacuation of blood clots is also challenging in MAS. Even small amounts of blood or clot significantly impair the view because they absorb the light from the endoscope.
Suction isn't as easy as in open surgery.
No. Standard suction, while easy in open surgery, is problematic in MAS because it rapidly removes the CO2 gas along with the fluid, causing the pneumoperitoneum to collapse and losing your working space.
So how is suction best done?
Careful suction technique is required. Ideally, the suction tip should be applied below the surface of any fluid pool to minimize gas loss. If suction is needed directly in the operative field, it should be used in short bursts. If tissue gets sucked into the tube, kinking the tube momentarily can release it. An alternative is using rolled gauze swabs or small sponges introduced through a larger port. They can be used to gently mop up blood without using suction and can also provide gentle retraction.
And robotic options.
Robotic systems usually have dedicated suction irrigation instruments, or suction can be applied through a non-wristed instrument via an assistant port. But the principle of minimizing gas loss remains.
Okay. Finally, another potential intraoperative problem that can cause serious, often delayed injury, electrosurgery misuse.
Right. Understanding the principles of electrosurgery is absolutely vital for safety in MAS. Inadvertent electrosurgical injuries during minimal access procedures are potentially very serious and, worryingly, often not recognized at the time they occur.
Mostly with monopolar.
Yes, the vast majority occur with monopolar diathermy, where the current passes through the patient to a return pad. The incidence is estimated at perhaps 1 to 2 injuries per 1,000 operations.
How do these unintended electrical burns happen?
Several mechanisms are described. Accidentally touching or grasping unintended tissue while the diathermy is activated. Direct coupling, where current arcs from the activated electrode to another nearby metal instrument, which then burns tissue it's touching. Insulation failure, where breaks in the insulating sheath of the instrument allow current to leak out and burn tissue along the shaft, often outside the camera's view. Direct sparking from the electrode tip, or even capacitance coupling, where current is induced in nearby conductors.
Is there a safer alternative energy source?
Bipolar diathermy is generally considered safer because the current only passes between the two closely opposed tips of the instrument, not through the patient's body. It should be preferred, especially when operating in crowded areas near vital structures.
What are the safety rules for using monopolar if you have to?
If monopolar diathermy is used, safety requires having a perfect visual image of the instrument tip and the target tissue, using the lowest effective power setting, avoiding activation in obscured fields, and meticulous attention to ensuring the instrument installation is completely intact before and during use. Ultrasonic energy devices are also mentioned as potentially improving safety as they use mechanical vibration rather than electrical current for tissue cutting and coagulation.
That section really highlights that despite the small external cuts, the technical demands inside and the potential pitfalls during minimal access surgery are significant and require constant vigilance.
Absolutely. Skill, experience, and awareness are key.
Moving on from the OR, let's discuss the road to recovery. What does the material say about postoperative care after MAS? Is it very different from open surgery recovery?
Generally, yes. Postoperative care after MAS tends to be more straightforward, with significantly less pain and fewer major problems compared to equivalent open surgery. However, the material strongly emphasizes the need for vigilance.
Vigilance for what?
It provides a crucial guideline, almost a mantra. If the patient develops a fever or tachycardia, a fast heart rate, or complains of severe pain at the operation site that seems out of proportion to what you'd expect for the procedure.
Alarm bells should ring.
Exactly. It indicates that something is wrong and necessitates close observation, investigation, or potentially intervention. This principle applies to all types of minimal access surgery. You can't assume recovery will always be smooth just because the incisions are small.
Okay, that's a major warning sign. What are some common, usually minor issues patients might experience after MAS?
Nausea is quite common, affecting perhaps up to half of patients to some degree after general anesthesia. It usually responds well to standard antiemetic drugs like ondansetron and typically settles within 12 to 24 hours. It can be made worse by using opiate pain medication.
And that distinct pain people sometimes get in their shoulder.
Ah, yes, shoulder tip pain. It's really important to warn patients about this possibility preoperatively, especially after abdominal laparoscopy. It's where deferred pain.
Not actually a shoulder problem.
No, it's caused by irritation of the diaphragm, usually by the residual carbon dioxide gas used for the pneumoperitoneum. The phrenic nerve, which supplies the diaphragm, shares nerve roots with nerves supplying the shoulder tip area. It's often worse around 24 hours after surgery, but typically settles within 2-3 days with simple analgesics like paracetamol or NSAIDs.
What about pain at the small incision sites themselves?
Port site pain and numbness around the small cuts is common, but usually mild and often worse if there's a small bruise, hematoma, at the site. It generally settles quickly within a few days.
Is it worse after chest surgery?
In thoracoscopy, yes, intercostal nerve pain, running along the line of the rib where the port was, can be more prominent and persistent, especially in patients with smaller spaces between their ribs. Nerve blockade with local anesthesia injected during or after the procedure can be very effective for this.
What if the port site pain gets worse later?
The material notes that increasing pain at a port site after 2-3 days, especially if accompanied by redness, swelling, or discharge, strongly suggests an infection, which would typically require antibiotics. Late onset pain at a port site, perhaps weeks or months later, particularly with a bulge, might suggest a port site hernia requiring assessment. Any failure to follow the expected recovery pathway warrants senior review and potentially imaging or even relook surgery.
How is pain generally managed after MAS? Is it less intense?
Analgesia requirements vary significantly depending on the patient and the specific procedure performed. Patients with a history of prior opiate use or chronic pain conditions can be more complex to manage.
Does the type of MAS matter?
Yes. Thoracic MAS, because of the rib cage involvement, often requires stronger pain relief, potentially patient-controlled opiate analgesia, PCA, sometimes supplemented with intercostal nerve blocks or epidural analgesia. For many abdominal MAS procedures, however, opiates can often be avoided or minimized, relying instead on regular paracetamol and NSAIDs, if not contraindicated.
Why avoid opiates if possible?
Primarily because opiates commonly cause nausea and vomiting, and they significantly impair gut motility, delaying the return of bowel function. But the key message is, disproportionate pain, pain that isn't controlled by the prescribed analgesia, should always raise suspicion of an underlying complication.
Are tubes like NG tubes commonly used in the post-op period after MAS?
Orogastric or nasogastric tubes might be used temporarily during some abdominal cases, particularly if the stomach needed to be decompressed during surgery, for example, for hiatus hernia repair. But they are not used routinely in all cases and are rarely used in other types of MAS like thoracoscopy or arthroscopy.
When are they removed?
Where used for routine decompression, the material suggests removing them before the patient fully wakes up from anesthesia if the procedure was uneventful. They are more commonly used, and sometimes left in longer, after major upper GI procedures like bariatric surgery or esophagogastric cancer surgery, where larger tubes might be placed.
What about getting back to eating and drinking? Is that faster after MAS?
Yes. Oral fluids and feeding can usually resume much more quickly after MAS compared to open abdominal surgery. There is typically no significant gut paralysis, ileus, except possibly following very extensive resectional procedures like a total colectomy.
So when can patients typically drink?
Patients can usually resume oral fluids as soon as they are fully conscious and alert, typically within 4 to 6 hours after surgery. A light meal can often be offered 4 to 6 hours after surgery if they feel hungry. Most patients are able to eat a normal breakfast the next morning. A balanced diet is generally recommended to support healing and recovery.
And urinary catheters, left and long.
Urinary catheters depend on the length and type of operation. For shorter MAS procedures, typically less than 4 hours, they are usually not required at all. If one was placed for a longer procedure or for specific reasons like pelvic surgery, it can often be removed before the patient is fully conscious or very early in recovery if the procedure was smooth and fluid balance is okay. Postoperatively, it's important to confirm the patient is able to pass urine adequately using a bladder scanner if needed to check for retention.
Are surgical drains commonly used after MAS?
Drains also depend entirely on the specific procedure performed and the surgeon's preference. They might be used after certain resections, or if there's a potential space where fluid might collect. If drains are used, their output should be carefully monitored and documented, perhaps hourly initially or more frequently if there are concerns about hub output, especially blood. Nursing staff must be familiar with managing the specific drainage system. The drain's location and size should be clearly documented in the operation notes. Continued significant blood loss from a drain is a clear indication for prompt re-exploration and must be reported immediately to the surgical team.
So while recovery is generally faster and smoother, the fundamental principles of vigilant postoperative observation and care are still absolutely crucial, particularly recognizing those warning signs that something might be wrong.
Absolutely, complacency is dangerous.
The material reinforces this by summarizing the key principles for safe MAS.
Yes, Summary Box 10.4 pulls it together nicely. It lists the core principles. Meticulous attention to safely establishing and maintaining the pneumoperitoneum, controlled and careful dissection of adhesions, ensuring adequate exposure of the operative field, diligent avoidance and prompt control of bleeding, avoidance of inadvertent injury to adjacent organs, careful technique to prevent diathermy damage, and finally, that ongoing vigilance in the postoperative period. These are really the bedrock of safe and effective minimal access practice.
Okay. With recovery hopefully progressing smoothly, let's talk about getting the patient home and back to normal life.
Right. Discharge from hospital after MAS is typically determined by standard clinical indicators and the patient's overall fitness to recuperate safely at home or in a step-down environment. A key driver and benefit of minimal access surgery is enabling earlier recovery and discharge compared to open procedures.
What are the typical discharge criteria?
Usually, the patient needs to be comfortable with simple oral pain relief, mobilizing safely, tolerating food and drink satisfactorily, and importantly, having passed urine after catheter removal, if one was used. Patients must also be given clear instructions on when and how to seek medical attention if they develop worsening pain, fever, vomiting, or other concerning symptoms after going home.
Can discharge happen very quickly?
Yes. The material notes that some units have established safe 23-hour stay protocols or even day case protocols for simpler procedures, even for relatively major minimal access operations, demonstrating how fast recovery can be for some patients.
What about the external stitches at the small port sites?
Skin sutures, if non-absorbable ones or staples were used to close the small port sites, are typically removed after about 7-10 days, similar to other surgical wounds. Often absorbable sutures are used which don't require removal.
And is the patient encouraged to get moving quickly once they are home?
Absolutely. Mobility in convalescence involves strongly encouraging early and progressive mobility. Even just getting out of bed to walk to the toilet soon after surgery is encouraged, as it's often remarkably less painful compared to moving after a large open incision. Active coughing and deep breathing exercises to clear bronchial secretions are also important to help prevent chest infections, particularly after procedures involving the chest or upper abdomen.
So early mobilization is really a key part of that faster MAS recovery story.
Definitely. Getting patients moving safely and early is crucial.
Now looking ahead, what's next for minimal access surgery? What further developments does the material discuss? Where's the field heading?
The text looks at advanced adjuncts, extra tools and technologies that enhance the surgeon's ability to recognize anatomy more clearly and precisely locate pathology during MAS procedures. These technologies are becoming increasingly commonplace in specialized centers.
Things like augmented reality, AR, how does that work in surgery?
Yes. AR in surgery is essentially defined as fusing computer-generated images or data with the real surgical field, overlaying useful information onto the surgeon's view in real time.
Why is that helpful in MS?
It's particularly beneficial in minimal access surgery, where the lack of direct tactile feedback can make locating hidden structures or differentiating between tissue types more challenging than in open surgery, where you can feel things directly.
Can you give a practical example of AR being used now?
A common and well-established example is using indocyanine green, ICG, fluorescence imaging. ICG is a fluorescent dye that's injected into the patient's bloodstream. When viewed under near-infrared light using special cameras and software integrated into the endoscopic system.
It glows.
Exactly. It makes certain structures or areas of tissue stand out, often displayed as pseudocolors like green on the monitor based on their differential blood supply or drainage patterns. This helps surgeons identify things like tumors, important blood vessels, bile ducts, lymphatic channels, or assess tissue perfusion.
So it aids precision.
Greatly aids precise dissection, helps ensure complete removal of diseased tissue, like cancer, and helps avoid injuring vital structures.
Where is ICG fluorescence imaging commonly used?
Its use is well established now in minimal access surgery for organs like the liver, lung, segmentectomy, kidney, partial nephrectomy, prostate, and colorectal surgery, checking bowel and anastomosis perfusion. It's integrated into robotic systems like the Da Vinci X, where it's often marketed as Firefly mode.
Are there other ways AR is used for navigation during MAS?
Yes, another application is overlaying preoperative imaging like CT or MRI scans that have been reconstructed into 3D models directly onto the live endoscopic view of the surgical field, or displaying it side by side on the monitor.
Like having a map superimposed on the territory.
Exactly. It acts as a real-time navigation system, guiding the surgeon to specific targets or helping them understand complex anatomy without them having to constantly look away from the patient to check scan images on a separate screen. These navigational techniques often originated in image-guided diagnostic procedures.
And the hybrid operating rooms we talked about facilitate this kind of combined imaging and intervention.
Precisely. Hybrid theater complexes, equipped with advanced intraoperative imaging, like CT or MRI scanners or high-end angiography suites, alongside the surgical technology, enable combining diagnosis and treatment in a single session.
Like the lung example.
Yes, navigational bronchoscopy is a great example. Using a pre-op CT scan to create a 3D roadmap of the airways, guiding a flexible bronchoscope out to a small peripheral lung nodule for biopsy, maybe placing a fiducial marker, like a tiny coil, under X-ray guidance, and then using that marker to guide subsequent video-assisted thoracoscopic resection or ablation of the nodule, all potentially in the same anesthetic setting. This reduces invasiveness and expands curative options, especially for patients who might not be fit for larger open resections.
What about things like surgeons wearing special head-mounted displays or augmented reality eyeglasses? Are we there yet?
That's definitely an area of intense interest and development. But according to this material, these are currently mostly used in simulation and training environments rather than routine clinical practice.
What's the potential?
The promise is huge. Real-time image guidance displayed directly in the surgeon's field of view may be showing multiplanar scan reconstructions or holographic overlays of critical structures. It could also enable communication with remote trainers or display vital patient data without the surgeon needing to look away from the operative field.
Why aren't they in widespread clinical use yet then?
The material notes several current limitations. Time lag between the real view and the overlay, the need for high-speed, reliable wireless connectivity in the OR, the physical weight and ergonomics of current headsets, and battery life. It's technology that is still under active development to become robust and practical enough for routine clinical application.
That's a fascinating look at how technology is enhancing visualization and precision in MAS. Let's zoom out now for our final thoughts, looking at the bigger picture. What does the source say about the future of MAS overall, particularly regarding training the next generation of surgeons and the potential role of artificial intelligence?
Well, the material reflects thoughtfully that while minimal access surgery has fundamentally changed how surgery is performed, it hasn't changed the underlying nature of disease or the fundamental principles of good surgery. Meaning that appropriate case selection, achieving excellent exposure of the surgical field, effective and gentle retraction, and maintaining high technical expertise and sound judgment are still absolutely paramount, regardless of whether you're using a scalpel, straight sticks, or a robot. The tools change, the core principles don't.
And training is highlighted as critical for the field's continued progress and safety.
Absolutely. Training the next generation is identified as key. And it's not just about teaching the technical dexterity needed to handle the instruments, but also fostering the crucial decision-making skills, the understanding of spatial awareness in 2D, 3D, and the innovative mindset required to adopt new techniques safely and push the field forward responsibly.
Is training perceived as more difficult in MAS?
It can be. The material notes that training can sometimes be perceived as challenging due to the trainer having less direct physical control over the trainee's instrument movements compared to open surgery, and potentially lower case volumes for complex procedures in some training centers. However, trainees today rightly expect comprehensive exposure to MAS, and adaptable, effective training systems and curricula are needed globally.
Given the digital and visual nature of MAS, simulation must play a huge role in that training pipeline.
It does, and increasingly so. The move to videoscopic and robotic platforms lends itself perfectly to simulation-based training. Simulation has proven benefits in shortening learning curves and ultimately aims to improve patient outcomes by allowing surgeons to practice complex skills and procedures in a safe, zero-risk simulated environment before operating on actual patients.
Are the simulators quite advanced now?
Yes, both videoscopic and particularly robotic platforms now have established sophisticated simulation programs, often integrated directly into the system or available as standalone units. These are often a mandatory prerequisite for trainees before they are allowed to participate in live surgery.
And robotic simulation especially sounds quite high fidelity.
It is. Modern robotic simulation modules are described as being very sophisticated. They accurately mirror the surgeon's console environment, offer a range of hierarchical training tasks from basic skills to full procedures, and increasingly support proficiency-based mastery training paradigms, meaning trainees must repeatedly demonstrate a defined level of skill and efficiency on the simulator before progressing. Combining simulation with objective mastery criteria is seen as key to optimizing its impact on reducing the real-world learning curve.
But there's a flip side to all this focus on MAS training, isn't there? The potential open surgery training gap.
Yes, this is identified as a real and growing concern in the material. As trainees rightly spend more time learning and performing minimal access surgery, they inevitably get less exposure to traditional conventional open surgery, especially for procedures commonly done minimally invasively now.
Why is that a problem? Don't we want everyone doing MAS?
The problem is that surgeons must still have sufficient open surgical experience and confidence to be comfortable and competent converting to an open procedure quickly and safely when faced with unexpected difficulties, major complications, or emergencies during a minimal access case. You need to be able to handle the bailout.
And the skills aren't always transferable.
Not entirely. Furthermore, the steps, anatomical approaches, and dissection techniques used in MES can be quite different from their open counterparts. The new generation of surgeons needs robust training in both minimal access and open techniques to be truly versatile and able to choose and execute the most appropriate approach for any given patient and clinical situation. They need the full toolkit.
It's about having a complete skill set, not just a MAS specific one. That makes sense. What about the integration of artificial intelligence, AI, particularly with the rise of robotic surgery? Where might that lead?
Advances in robotic surgery, with their digital platforms and sensor capabilities, create significant opportunities for greater AI integration. The material outlines several potential advantages.
Such a
Enhanced clinical decision support during surgery, for example. AI could provide real-time prompts or warnings if the procedure deviates from an optimal workflow, or automatically detect and highlight critical anatomical structures at risk of injury on the surgical field overlay.
What's the ultimate goal of bringing AI into the operating room like this?
The overarching aim is to leverage AI to help streamline procedural technique, reduce the potential for human error, improve consistency, and ultimately enhance patient safety and outcomes. AI could enable intelligent operating rooms with automated optimization of things like operating table position, lighting, and even room temperature based on the phase of the procedure.
Could AI take over parts of the surgery?
Further down the line, more advanced systems could potentially incorporate a degree of supervised autonomy for performing certain basic repetitive surgical tasks like suturing or dissection under the surgeon's oversight. The material even mentions some impressive preclinical research success, like the STAR robot, demonstrating superiority over human surgeons in complex tasks like experimental bowel anastomosis on pig tissue.
Wow, that sounds almost like science fiction. But translating that kind of lab success into safe, routine, real-world surgery must be incredibly complex.
Oh, it's far from simple. The material acknowledges this. Real-world clinical application requires a very deep understanding of complex surgical workflow and the ability to integrate vast amounts of dynamic, often unstructured data from the unpredictable operating environment, including OR setup variations, tool usage patterns, diverse camera views, and highly variable patient anatomy to create the comprehensive, reliable training data sets needed for robust, deep learning algorithms.
And the ethical and practical hurdles.
Exactly. There are also significant challenges around data protection and patient confidentiality, complex ethical considerations regarding machine decision-making, and fundamentally defining accountability when autonomous or semi-autonomous systems are involved in patient care. Who is responsible if the AI makes a mistake?
What are perhaps the most promising or near-term applications of AI in MAS according to the material?
Things like enhanced object detection, more reliably identifying anatomy or instruments in the camera view, improved speech recognition for controlling OR equipment, automated video characterization, AI understanding what phase of the operation is happening based on the video feed, and integration with next-generation diagnostic technologies are mentioned as promising areas.
Like real-time tissue analysis.
Yes, real-time metabolic profiling or tissue diagnosis is highlighted as another exciting frontier. Imagine being able to identify cancerous tissue versus normal tissue based on its unique chemical signature in real time during dissection, perhaps using technologies like the iKnife, which uses rapid evaporative ionization mass spectrometry. Rhymes. That could guide surgical margins instantly.
And how might AI impact surgical training specifically?
AI, especially when combined with advanced simulation platforms, holds tremendous potential to dramatically improve the fidelity and effectiveness of simulation training. It could help create highly realistic, adaptive real-world training environments based on analysis of vast amounts of real surgical data. This could lead to sophisticated, AI-driven stepwise tutorial systems that mimic expert bedside teaching, providing personalized, objective feedback based on performance against standardized proficiency benchmarks, all integrated seamlessly into training programs.
All this incredible technology sounds amazing, but the material brings it back to Earth with a major obstacle.
Yes, the material identifies the major ongoing obstacle as cost efficiency and device financing within increasingly resource-constrained global healthcare systems. New technology is expensive.
So the technology is there or rapidly developing, but the economics of adopting it widely are a huge hurdle.
Exactly. It requires ongoing, often difficult dialogue between surgeons advocating for new tools, hospital administrators managing budgets, and national policymakers deciding on healthcare funding priorities.
What's needed to navigate this?
Rigorous outcomes research is essential. As new technologies are adopted, we need high-quality studies to provide a clear evidence base, comparing them not just to older techniques but also to each other. Understanding the true comparative effectiveness, considering both clinical outcomes and overall cost effectiveness across the entire patient journey, is crucial for identifying which technologies genuinely offer lasting improvements in patient care and represent value for money, rather than just being technically impressive but ultimately unsustainable novelties.
It's a field constantly pushing the limits of what's possible technologically, but it must remain grounded by the practical realities of costs, rigorous training, and ensuring those fundamental surgical principles are always maintained.
Precisely.
The material closes with a quote that seems particularly resonant, written long before most of this technology existed.
Yes, it includes a powerful observation from the renowned British surgeon Sir Berkeley Moynihan dating back to 1920. The cleaner and gentler the act of operation, the less the patient suffers, the smoother and quicker his convalescence, the more exquisite his healed wound. Moynihan was known for advocating the open sharing of surgical knowledge to improve patient care across the board.
That quote resonates so deeply with the core aims and aspirations of minimal access surgery, doesn't it? Written decades before these techniques really became commonplace, it captures that fundamental ideal of minimizing the harm caused by the surgical act itself.
It truly does. You could argue that minimal access surgery in all its forms is perhaps the most significant and widespread expression of that Moynihan ideal seen so far in the long history of surgery.
Well, we have certainly taken a deep dive today. We've gone through this incredibly detailed material to understand minimal access surgery right from its foundational definition and its surprisingly long history. Through the diverse array of techniques, the compelling advantages, but also the significant limitations and challenges. We've explored the transformative role of robotics, the critical importance of meticulous patient preparation, and perioperative care.
Navigating the potential complications inside the operating room.
Exactly. following the recovery journey, and finally peering into the exciting and sometimes complex future possibilities with advanced imaging, augmented reality, AI, and the crucial ongoing challenges of training the next generation of surgeons safely and effectively.
It's clearly a field that is incredibly complex, constantly evolving with technology, but fundamentally driven by that core principle, seeking better outcomes for patients by reducing the trauma of surgical access itself.
It has had such a profound and lasting impact on surgical practice worldwide. And thinking about that Moynihan quote again, and these future discussions around AI, robotics, and potential autonomy, it raises some truly interesting questions for all of us involved or simply interested in the future of healthcare.
Yes, the big question is, how do we ensure that as technology becomes ever more powerful and sophisticated, we maintain that unwavering focus on the patient, minimizing their suffering, accelerating their recovery, achieving excellent long-term outcomes?
It really is about finding that delicate, ever shifting balance between leveraging incredible technological advancements and rigorously upholding those fundamental, timeless principles of surgical care, judgment, skill, ethics, and empathy. What does it truly mean to master that blend of art and science in the operating room of tomorrow?
That's a great thought for you, our listeners, to consider as we wrap up this deep dive.
Indeed. Something to mull over.
Because ultimately, the patient must remain at the absolute center of everything we do, no matter how complex or impressive the tools become.